Well, thank you, Dr. Mead. And before we go to the panel, we actually have a couple questions for you, a couple follow-up questions for you.
Okay.
How do you support a colleague or colleagues who are demonstrating signs of burnout?
So, communication, just like you would with a patient or a client, I guess, showing signs of trauma maladaptations. So, ask how you're feeling. Do you feel safe? You've got to have that relationship, and hopefully that relationship has been built previously. I guess if you don't have a good relationship with that colleague, talk to somebody else that does in as confidential a way as possible. Which reminds me, I haven't spoken a lot today about confidentiality, but that's always extremely high on our list of practices within trauma-informed care, and again, dealing with staff as well. Supporting them in perhaps they haven't been very mindful of their own work-life boundaries. Explore those issues with them. All of the things that we've talked about this afternoon. Sometimes burnout, if you look at the literature, burnout is a little different to vicarious trauma or compassion fatigue. Burnout is sometimes more of, to my mind anyway, a boredom with work, a routine with work, of not really being engaged with work, you know, showing up for work for the paycheck, but really just doing what you have to do and going away again. And I mean, I don't know, Jason, you might disagree with me about that, but I see burnout as a little different, or just being really tired and not stimulated so much by your environment.
Yeah, I find it's more the end stage, like where when somebody's at burnout, it's almost like they've gone through the compassion fatigue,
Yes.
and they're just going through the motions is the best way to describe it.
And so for that, what would you, I mean, probably some of my colleagues might be able to help here. So maybe it's time to move into a different job setting, maybe not leave the organisation, but look at the roles that you're doing within your job and trying to change things there a bit, do a bit more admin stuff versus, you know, client care. Try and find a way that brings you back and brings that passion back into your work.
Yeah, and I think you gotta take it on an individual basis, and it is based on communication with whoever you're working with, right? So if it's a colleague, I think looking at workload is a good idea, and figuring out ways that you can critique that workload or curtail that workload so that they do have some time to kind of get their head around it or get their emotions around it and kind of get that recharge time. Because if you just keep stacking stuff on them, or what you're doing right now isn't working. So you need to find something else, and you have to be honest about that. Like if they're at that point, you need to have that communication, hopefully have that relationship built up where you can say, what's happening right now isn't working, and I'm worried about you. And hopefully if you do have that relationship, they can take that advice.
Thanks, Jason. And we've already got some questions for the panels. I'll go for one question here. And then for studio audience, if you guys want to line up at the mics, if you have any questions, that would be great. But Jason, you spoke about work-life balance on an individual scale, and we've been talking about that with Dr. Mead's comments as well. This question is, I'm curious what your organization may be doing to ensure workplace or group resiliency and that kind of balance. And that can be for all three of the panel members. What do you guys have to do at the whole workplace?
So at the workplace, it's there was a tendency to want to, like we're supposed to be done at 5. So there's a tendency to want to just keep going. And so we had to have some pretty serious discussions as a group. And I'm glad you said that, where it's a group thing. It's not just one person. And we had some discussions about, we need to make sure that when we're done work, we are done work. And and you're going home, whatever you're doing, if it's that important that you can't leave it, then you should be talking to other people to see who you can tag in to help you with that project so that you can get it done in time. But what we're doing can be left till the next day. And that's, for us, when it comes back to harm reduction, it's just that harm reduction, not harm elimination. And so there's always tomorrow. And you need to remember that, because especially in the work we do, you feel like if you don't get it done today, there's not going to be a tomorrow. There will always be a tomorrow. So.
Actually, at the Friendship Center, we, what Dr. Mead was talking about, having birthdays celebrated, we often have staff meetings where we bring in a cake and celebrate the birthdays during that month. We also have other activities that we engage in. For instance, maybe this is a secret. I'm telling anyway. We'll have a staff poker party to raise money for the United Way. Don't tell. It's all just our shh. It's to raise money for the United Way, and it's a staff activity, and we do a lot of those kinds of activities. We also have retreats periodically, where we will go and have it's a working retreat, and we have exercises that we do during the course of the retreat, but usually it's somewhere at a spa or something of that nature. In fact, our residential school workers are gone with the elders today to Edmonton, and they're having a spa night tomorrow, so I'm a little bit jealous about that. But the reality is the work is stressful. You know, I mean, it's no secret. We all do the best that we can do. And I was really interested in compassion fatigue. I love that terminology, Dr. Mead, because it's really true. And when I was thinking of it relative to burnout, I was thinking burnout is from within, and compassion fatigue is from without, from outside of ourselves. But it creates the same kind of difficulties in our own personal lives. But so we do as much as we can. We often have we have a staff fund, and we often go out to lunch at a restaurant together as a group, because all of us are working in the trenches. And any of you who are working in small organizations know that it's almost impossible to get everybody together on a regular basis to even know what you're doing as a member of the staff, because everybody's doing their own thing and working incredibly hard and in incredibly stressful jobs. So when we do go out to have lunch together, we'll go, you know, for a pasta, or we'll go for Chinese food, and we'll all go together. And our staff fund that we've all been paying into picks up the tab, and that makes it really special.
One thing I wanted to mention too for day-to-day stuff at Aid Saskatoon is we have meetings twice a week, like staff meetings, and what we do is we take time at the start of the meeting to have personal check-ins, so people can kind of say what's going on with them in their personal life, and they can always opt out if they don't want to, but it was something that we had implemented, and then we got too business-oriented, probably due to me, ironically, and then we had to have a talk and say, no, the personal check-ins is worthwhile. It takes 15 minutes, 5 minutes sometimes, you know, and it's very important for us to have that, because then, especially like you're in the trenches like that, that's what it feels like. And so when you are that and you're having a bad day because of whatever's happening at home or whatever's happening in your personal life, or I didn't sleep last night because the kids were sick, then you can let your colleagues know that. Then your colleagues know to give you that grace period to maybe don't ride you about that report today, or don't ask you about the kids today. So it's something that we do weekly, that we do it multiple times a week, but it's important for us to have that time set aside so that we can kind of be human.
Can I just say that's really good. I have not thought of that before, and that would work really well at our work environment, so I can take that back to them, I think.
Thank you. Another question for the whole panel. Is it better to refer a client to another care provider if they are unresponsive to your attempts to engage them, or should you continue to try and develop their trust?
Okay, I'll take this one first. Yes. No, I think that it really depends on the relationship and actually the needs of the client. If you know that your service is going to can offer the most to that client, then I think it's incumbent on us to try to engage them as best we can. However, I think I said it earlier in my speaking, we're not all things to all people, and different relationships require a different skill set and a different personality. And even within our own organization, that I may not be the best person to talk to some individuals. So I may find a different person in our little organization to refer that individual to. That's not abandoning them, and I think that it has to be made abundantly clear that if I'm finding another service for them, they're certainly welcome to come back and to see me as well, but that I think that that their healing can be enriched by including another dimension and another individual in that process. So that would be my...
Yeah, with us, we have, like in my department, for instance, there's 3 of us. And if somebody's working with me and they decide they don't want to work with me anymore, or they're not getting along with me, or maybe they're disengaging, it's no sweat off my back if they go to Darcy, and I'll let them know, you know, Darcy's an option, or Megan's an option, or Sarah Dawn's an option, and they can go talk to them, and they can build up that relationship, because who knows why they don't want to talk to me. Like I'm the way I am. I'm pretty straight-laced and pretty like to the point, and so that might not be for them, right? So somebody else on the team might be very much more the open heart. They're wanting to hug them, you know, like let them know everything's okay. So that might be the better person to go talk to. So, and we were very open about that, but in terms of referring people to other agencies, if they're not engaging with us, usually that's a conversation they might just be coming into the drop-in center to hang out. So if that's what they want, that's all they want. They know where we're at, but we refer people to other agencies all the time, because like I said, if we're not the best fit, somebody else might be. And so whether it's another CBO, or whether it's you know, publicly like with the health region, so whether it's an addictions worker or a counselor, so we're constantly referring people back and forth. And what we find is you have multiple people on that care team, so that you have you know, you might have their doctor, then you might have their specialist, their HIV doctor, then on top of that you might have their PO, so their probation officer, then on top of that you got their us, and then they might have an addictions worker. And so what we try to be is a facilitator between all those services. So, and we're lucky because the health region and the Ministry of Health funds us to provide transportation to appointments. So we can be those facilitators, especially for people that don't have phone or a place to live. So.
I can maybe speak to the residential setting a little. So we take women at any stage of their addiction cycle, so we can have people that have been using right up until the hour before being admitted to our service, or they might have been, you know, clean and sober for weeks or months or even longer before coming in for treatment. But we, you know, sometimes run into a problem of someone really not settling in, not establishing relationships with the staff, sometimes establishing relationships with their co-residents, but sometimes they're not particularly healthy relationships. And if we see someone struggling to engage, then we will have that conversation about, well, maybe it's just not the right time for you, you know. We don't battle on and say, okay, you need to stay and keep trying to work at it, because that is just disruptive for the community as a whole. It's very difficult for the staff, and it's very difficult for the other women in the residence. So, and often just having that conversation about it seems like perhaps now is not the right time for you will help them to refocus and reprioritise and change their mind about that. Or we encourage them to go home and come back again in a month. Like we'll say, you know, we'll hold a spot for you, or reapply when you do feel ready. So always taking it back to the client and what the client's needs are.
Thank you. This comment is, I appreciate the power of language, but have never considered client as disrespectful or disempowering. Can Jason speak more to his choice of PWAS or PWAS? And what about Dr. Mead and Patty? What do you guys call your clients?
So it's not me, it's AIDS Saskatoon. As much as I'd like to think that I'm AIDS Saskatoon, I am not. But for us, it comes down to client. The inherent meaning of client is we kind of we're like owner. They're in debt to us, basically. Like, we don't view it as that. We view it as they are choosing to access services with us. They aren't our client because we don't have any ownership over them. They are choosing to come in to work with us, and they could choose at any time to not do that. And so they're a person who's coming in to access services, and it's an anagram, and I know language can be, with what intent you say it with more than anything, and it comes to that communication of tone, and it's not just word choice, right? So, but for us, that's just what we do. We like the word PWA. Our PWAs like the word PWAs. So it's just what we use.
I think I alluded to the fact that I'm not really comfortable with the word client when I'm dealing with my the gals and the men that come in to see me. But for lack of another word, because they're not my patients, I utilize that word. Certainly I utilize it when I'm drafting support letters for them for any more formal purpose. But, you know, several of my clients call me auntie. Some of them call me mom. And I'm comfortable with that, depending on the relationship we've established over in some cases 3-4 years that I've worked with them. I mentioned a young woman earlier who called me 2 days ago. She calls me mom and has called me mom almost since we first met. And I think I accept that term. It's her term. Do I consider myself to be her mom? No. But I am her mentor in many ways, and I am her support system in many ways. But as I say, client is the word that we're called upon to use, for lack of another one. I like PA. I'm not sure that I can figure out PA, get it around my tongue very well, but I do like the concept. I love the concept of it being something different than client.
Okay, so for us, again, same, client isn't a very nice word, but it's I work in an interdisciplinary team, and that's typically what social workers and counsellors call their clients. So patients is a very doctory type of term. You'll notice when I'm talking, I flip between patient and client and residents because we're in a residential treatment setting, we call the women sometimes residents. But it's nicest to use first names. And in terms of how they address me, that is always a bit of a sticky point, because people always assume that doctors need to be called doctors or want to be called doctors, and there's that kind of hierarchy that goes with being a doctor. But interestingly, some of the patients or clients flip to calling me Mrs. Mead instead of Dr. Mead, which is fine, I don't mind at all, but I think for them it just kind of makes it a more kind of normal relationship, less power imbalance there, which is so important. And many of them call me Annabelle, and I'm totally fine with that, as are the other doctors that work in our service. So yeah, this language stuff is you know, emotive, isn't it, and tricky sometimes. And I noticed just on that you don't like the term trauma survivor, and actually prefer trauma victim. So, you know, for me, I prefer survivor to victim, but yeah, again, it'd be nice to have something totally different.
Absolutely.
Yeah.
Absolutely. And I need to say that most of my clients call me by my first name.
Mm-hmm.
In fact, all of them call me by my first name if they don't call me by auntie or mom.
Yeah.
And their kids call me Kokum when they've come in, because we have a lot of people come into our lobby. We have a couple of little kids that have been coming into the lobby since they were days old, and so we buy them Christmas presents, and their family. And I think that's the thing about a Friendship Center movement, is that our clients are effectively family, because they come from a tradition similar to our own. They come from a culture that we're part of, and some of the experiences that they've had are similar, if not the same, as the ones that we've experienced, and so they are family. So it becomes quite informal, and I think that's why client becomes a kind of an icky word to use on a regular basis.
Yeah, and most, like, in terms of titles or whatever, like, most people call me Darcy, who's one of my coworkers. So, you know, you take what you can get, I suppose.
Amy asks, what can I do as a frontline worker when I know I am referring a client to another facility or service that is not trauma informed, that don't have that knowledge base?
For us, when we refer somebody to another service, we're very honest about what that service is about. So if we're making a reference or a referral to the Salvation Army, we tell them straight up, without any judgment, if you have any warrants out for your arrest, they will call them in on you. And then whether they choose to get a referral to the Salvation Army or not is up to them. Because if I refer that person, because for me it's all about keeping somebody engaged. So if I refer that person to the Salvation Army and I didn't tell them that, who sent them to jail in their eyes? Not their decisions from the past, because that's a whole nother mess, but I did, right? And Aid Saskatoon did, and the 601 did. So whenever we're referring somebody to another place, we let them know what it's about. So if somebody's starting up the methadone program, we tell them what the methadone program's about. We don't pull any punches. You know, we might try to make certain things a little bit more favorable and highlight certain aspects, because it's really easy to get stuck on the stuff you don't want to hear. But there's all these good stuff, especially when they've been burned so many times. So when you highlight the positives of whatever you're referring them to, but let them know the negatives. Don't sugarcoat it. Don't lie about it. Don't purposely omit details. They need to know everything, because this is their life that you're talking about. And I can't stress that enough. I've said it multiple times. This is their life. So if you're referring somebody to a program, you need to let them know the whole deal so they can make an informed decision. Because if you're withholding information, that's not an informed decision. That's coercive. That's a coercive, you know, and you don't want to get into that.
We actually, I'd like to just say, we actually act in much the same way as Aid Saskatoon. We certainly make sure that people are aware of exactly what they're getting into if they're going to a different agency or organization. One of the things that I am serious about and find it's absolutely necessary for me to be able to justify my making that referral is that I'm making that referral by ensuring that I include the positives that agency may be able to provide for them. Very honest about the limitations, very honest about the requirements, and if we're talking about methadone, or we're talking about any kind of antiretroviral therapy, or for that matter, Ribitron, or any of the Hep C medications, I'm straight up with them about the difficulties that they may encounter, but I'm also really clear about the end result if they can manage, and ensuring that they know that we're there for them to support them in any way we possibly can to make sure that they can survive through other treatments or working with other agencies.
And one real quick thing too, like when you're referring somebody to an agency, don't assume that they're not going to engage with that agency based off your experience with that agency. So my job is to let them know what these agencies offer, they offer, and then make that referral so that they can go. So like the doctors are good. They can make up their own mind once they get in the room with that doctor whether they like him or not. You know, their counselor, if they don't like him, they won't go back to that second appointment. So you want to give them that information, but you don't want to make it so weighted that you're basically making the decision for them, right? And that's where it comes back, where you let them know that you're there to support them no matter what the outcome and no matter what they decide. But usually if you get them into a room with the professional's in their job because they're good at their job. So getting them in that room is important.
Thanks. We're getting close to the end of our time, and we won't be able to get all the questions, but I just have one final kind of question for the whole panel. Regarding trauma-informed care, what would you guys like to see more of within the health regions that you're working in, and what maybe you want to see less of? Or you can answer just one of those, or you can answer both of those.
Well, you can start, I guess. For myself, I would like to see more support for frontline staff in terms of nurses, especially. I feel like it's a very overworked group of people, very underappreciated group of people. You know, shift shortages, all that coming through. I would like to see that. And I was actually talking during the break to Dr. Butt, and he had mentioned the idea of pagers for people when their medications times are when they're in the hospital, so they know to run back up to the room. So there's less of that tension, right? So it's innovative thinking, and it's just looking at a problem from a different angle instead of just saying we can't deal with it. There's always a way around it if you're open to it, but you have to be open to those solutions instead of just putting the blinders on and saying, well, they're just not in their room. So. And that applies to multiple situations where you just need to look at it from a different angle. If what you're doing is not working, don't keep doing it. Like, it's pretty simple. Like if what you're doing isn't working, don't continue on it. Like try to figure something out and use your colleagues around you. So I'd like to see that. In terms of what I'd like to see less of, you know, the stigma is quite huge. When I go visit people in hospital, they have HIV, I got a gown and glove, and they don't have any open sores on their body. They're not even there for the HIV really, they're there for another thing. But I got a gown and glove every time because they're HIV. Yeah, it's crazy. And so when you go into the room and you'll have nurses and orderlies coming in to tell you, you got to get a gown and glove on. Where's your gown and glove? Where's your gown and glove? And to me, that's crazy, because if they were to walk out of that room, I could shake their hand without an issue. So it's a little different. So.
Well, my perspective, of course, is on cultural competency, and I think what would be really, what I would like to see more of in the city is opportunities to share with individuals who are frontline workers the stories. It's not about trying to hammer it home to people. It's about allowing people to hear the truth about the situations that a lot of their clients have been subjected to, and having them understand more and be more empathetic as a result of that information sharing that we're able to do with agencies and healthcare providers. What I'd like to see less of, I'm shocked about about Jason having to gown up. In 1989, I had a brother-in-law who was sick, and he didn't. In those days, he really didn't know what he was sick with at the beginning, and then he was in Mount Sinai Hospital in Toronto, and I would go to see him, and the cleaner would come in, gowned up, masked, the whole gloves. It was just horrific. That was 1989. No one would touch him, and one of the things that he was so traumatized by was the fact that no one would touch him. And so when I'd go and see him, I was in school in Toronto at the time, and he would just say, would you just lay down beside me? And so I would get up on his hospital bed and lay there with him until he could rest, because he was really sick. And of course, in those days, there wasn't much hope, and he passed shortly thereafter. But I really thought that wasn't the case anymore. I thought that people were more informed. I'm sad to know that in a hospital setting in 2015, that people are so ignorant that they require us to wear gowns and gloves. So that's what I don't like.
Can you just go to the mic? Yes.
I worked in a hospital setting for about 15 years, and in that time frame, in the time that I've worked with HIV positive people, I've never known anybody to have to gown and glove to go into a room because they were HIV positive. Oftentimes it's because they have a different superimposed infection, and or because their immune system is so in jeopardy that they're wanting to protect that person from us. Not necessarily that we're trying to isolate the person, although I know when you enter somebody's room with that gown and glove on, you do further isolate them. But it's from a need to protect them, not from a need to isolate them. From my personal experience in the hospital, I've never had to gown just because they were HIV positive.
Yeah, like, so I visit people quite regularly in the hospital, and I can tell you I've been in to see people who have endocarditis who are HIV positive, and those who aren't. I've been in to see people who have pneumonia who are HIV positive, and those who aren't. And without a doubt, when they're HIV positive, it is gown and glove time.
I think that's really sad that you've had to experience that, and I
It-
think
yeah,
it's
it's
really
not-
sad
it's
that
not-
the people have had
And
to
that's what it
experience
comes
that.
down to, right? So it's the person in the hospital room, and usually once like there's certain wards that know me, they don't ask of me of that because they've like I've come and talked to them and they've heard my spiel and they don't want to listen to me rant at them for 20 minutes. But sometimes it's not worth the effort because who's the reprisal going to be on? Is it going to be on me? I could take it. Is it going to be on the person?
Yeah.
Is that going to cause them to disengage with me because I picked a fight they didn't ask me to pick for them?
Yeah.
So it's one of the more troubling things you see in the healthcare system.
I think kudos to you for spreading that, like for informing people and for being an advocate for those people then, because it is disgusting if that's what they've had to go through.
What's
I'm
more,
glad I was never a part of it.
sorry. What I find more disgusting is a good word, is the fact that Jason knows the truth. Jason knows the risks that are out there. However, when a family member comes in to see that same person who is going to go home to the reserve, who is going to go home to their family, and they've had to gown up in order to even visit a sick family member, they're going home with all the preconceived and prejudices and against a person with HIV. How are we going to expect them in the future to deal with someone that they may meet in the community and be objective about what are the risks? You're not having sex with them. You're not sharing a needle with them. You are safe.
Thank you for the question. We've got about a minute left, so we'll leave Dr. Mead.
Okay,
to finish off.
just two things. I just want to say I work for Provincial Health Services Authority in British Columbia, and just to answer that question very briefly, we have had some fabulous forward movement with bringing trauma-informed practice to the Health Authority. There's a trauma-informed practice steering committee that's been meeting for over a year. A couple of weeks ago, we had a leadership retreat for all the leaders from multiple disciplines from Children's and Women's Hospital. They send out a monthly news bulletin with little kind of tip highlights and practice pointers via email to everybody, to all staff. And we've got compassion fatigue workshops coming up in the next month on 3 different days, and all staff are asked to go to it, and they're providing the funding for the backfill, so we need some financial support from our bureaucracy behind things as well. So lots of good things happening there. And my final thing, 2 recommendations for you. This book is called Becoming Trauma Informed. I use this a lot in my work on trauma informed practice. It's from CAMH, which is the Centre for Addiction and Mental Health. And the other resource, which is very helpful and I can highly recommend, and this is easily found online in a PDF version online, it's Trauma Informed Practice Guide from 2013. And if you just Google Trauma Informed Practice British Columbia, you'll find this book.
Thank you, Dr. Mead. Thanks, Jason, and thanks, Patty.